Amy, this is Dr. John Bennett. Continuing on the second day of the online conference for ASNS, the organization Asian Congress of Neurological Surgeons, led by Ipcherian. Today we have the pleasure of having Sunil Munakomi, MD, a neurosurgeon from Nepal. He's going to tell us about pathogenesis of traumatic brain injury. But first, let me introduce our special guest panelist, Ipe. Good morning, Ipe.
Good morning. Good morning, everybody. It's an honor to be present here. Yesterday's sessions were very good, excellent. So let's see what is in store for today.
Great. Yeah, we had a great hangout with Ipe and Roberto Herrera yesterday, Argentinian neurosurgeon. And we have a late arrival guest, but we'll introduce later. And we'll turn it over to Sunil. Good morning, Sunil.
Good morning, sir.
Okay, could you please just say a few remarks about who you are, where you are, your background, etc., before we go into your presentation, please?
I'm currently working as a senior resident in College of Medical Sciences, Department of Neurosurgery. I'm working on the Dr. Ipcherian, and I'm just planning to appear for the final examination in coming months. In this talk, I'll be talking on basically the newer insights to pathogenesis of traumatic brain injury, and I hope it will give us some new insights to pathogenesis of TBI.
Okay, very good. Okay, I'm gonna put up your PowerPoint here, and you can just direct me through it. Hold on here, I had it up there. Okay, here we go. Okay, you see it? You see it? Okay, Sunil?
Yes, sir. Thanks, sir.
Okay, just direct me. Okay, thank you.
So the topic of my presentation is newer insights to TBI. As you know, TBI is one of the leading cause of morbidity and mortality in any subset of population throughout the world. In any subset of population, we will see TBI leads to major morbidity to the patient. So in this talk, I'll be talking about newer insights to or recent advances to our understanding regarding the pathogenesis of traumatic brain injury. Next slide, please, sir.
John, next slide, please.
Oh, is this a slide?
Yes, sir. Thanks, sir. As you know, TBI is a silent epidemic. If you look at the pathogenesis in the global front, TBI is one of the major causes of morbidity and mortality. A recent study shows that the incidence of TBI is roughly around 200 per 100,000 population. And a recent report from WHO estimates that TBI is going to be major cause of morbidity and mortality. In fact, it's going to surpass ischemic heart diseases and cerebral vascular accidents in coming years by around 2080. So it's a major health concern, and it's a major public health burden as well, especially to nations like developing nations like us, where the infrastructure, the preoperative and the post-operative management is still in the developing phase. TBI is a major issue. So in this talk, I'll be talking about how we can have newer insights to TBI. The next slide, please, sir.
Okay.
John, could we maximize the slides, please?
That's as big as we get. Okay.
So if you look at the impact of traumatic brain injury, it's a major cause of death, especially among young adults. Now, young adults are the building blocks for any developing nations, because if you have major subset of population in the adult age group being affected by traumatic brain injury, then the economy of the nations also suffers. So what we need to know is that in order to minimize the effect of traumatic brain injury, our focus should shift into prevention of traumatic brain injury. Then our focus should shift on how we can manage those people who are suffering from traumatic brain injury. So in this talk, our main aim is to enlighten upon new insights to pathogenesis of TBI. The next slide, please, sir.
Is this the right slide?
Yes, sir. So if you look at the pathogenesis, one of the main issues is glutamate hyperactivity.
We are not seeing the slide. We are not seeing the slide. Sorry.
Okay, you're not seeing the slide? Okay. Thank you for telling me. Okay. Okay, you seeing it okay?
Yeah, now yes.
Okay.
So if you look at the pathogenesis of traumatic brain injury, one of the main factors that has implication on the pathogenesis is glutamate, also known as glutamate hyperexcitotoxicity. Now what glutamate does is it leads to influx of excessive amount of calcium within the cells, leading to activation of fast fall ligand, leading to apoptosis. Also glutamate is also postulated to pathogenesis of leading to activation of endonucleases or proteonucleases that cleaves the cytoskeleton of the cells, leading to cell death. Also, glutamate has been postulated to activate different killers within the cells. One of the recent advances is that glutamate plays a role in apoptosis as well as parthenosis. Now, parthenosis is nothing but it is same like auto killing of the cells. What happens is traumatic brain injury. It's a hyperexcitotoxic state. So there is activation of different cells. Now, when different cells gets activated, what happens is there is activation of PRAP enzyme known as poly-ADP ribose polymerase pathway. Now, what this does is it it leads to excessive implication or excessive use of ADP, adenosine, or which leads to the scarcity of adenosine for normal growing cells. So, what it does is that it kills the normal cells, that traumatic brain injury cells, and also it suffocates the other normal cells from adenosine, which is the building blocks of any cells. So it is killing the cells by apoptosis, and also it is leading to killing of the surrounding cells by the pathogenesis of parthenosis. So glutamate toxicity is one of the major concerns in traumatic brain injury. Next slide, please, sir.
John, I don't think we should see Sunil at all. I think we should see only the slide, because right now we're not seeing the slides. We're seeing only Sunil. So I think his video should be muted, and then the slide should be on while he can talk.
Okay, yeah, the problem.
I can see the slides.
You don't see the slide, Sunil? You see the slide now?
Yes, sir.
I can see the slide. I'm Sina.
Yeah. Okay, you can see the slide, Sunil?
Yes, sir.
Okay. Go ahead. Tell me when you can. Okay.
Yeah, yeah.
Okay. Okay. You want the next slide or this slide?
Same slide, sir.
It's okay.
But
Next
now,
slide.
yeah, yeah.
Next slide. Okay.
No. Same previous slide, sir.
Okay.
Yes, sir. So
As
if you
soon
look
as,
at the
as soon as Sunil starts speaking, we are not seeing the slide, John. We would
Okay.
like to have the slide on.
Okay. Just
Yeah.
tell me. Next slide, please.
Yeah.
So if you look at the pathogenesis of TBI, what is that? It causes downregulation of glutamate transporters. So glutamate cannot be transported from the cells into the extracellular compartment. So if there is excessive amount of glutamate, it leads to glutamate hyperexcitotoxicity, leading to apoptosis and parthenosis. Next slide, please, sir.
See it okay?
So one of the major critique of glutamate toxicity is that one of the studies has shown
You can see the slide, Sunil?
No, but as soon as Sunil starts speaking, the slide is going off for me, John. I don't know what for what.
You know, I don't know what's that's the problem when I do the slides here. Yeah.
Yeah.
Can you hear me?
Yes, I can hear you. I can hear you. Okay.
I can see the slides of Sunil. I have to click the slide. That's all.
Can you see the slide? Okay.
Yeah.
Okay.
Professor Sinha?
I'm sorry, because of light power cut, I could be connect.
Yeah, Professor Sinha, how are you?
Yes, I'm fine because there was power problem, so I couldn't connect that time.
Okay.
Okay. Is this the right slide, Sunil?
yes, sir.
Okay. Just tell me next slide very distinctly, please.
Yes, sir. So one of the major critique of glutamate, role of glutamate in traumatic brain injury is that one of the studies has shown that the amount of glutamate is present in the brain only for around 5 minutes. So what they are saying is that it's not because of the glutamate that the cells are dying in case of traumatic brain injury. What they are saying is that it is because of the spreading depression due to sodium extrusion. That is, sodium goes out of the cell, leading to hyperpolarization because of the calcium influx. And this is the cause of the phenomenon, or this is the cause of the pathogenesis that leads to traumatic brain injury rather than the glutamate. This is one of the critiques regarding the role of glutamate in TBI. Next slide, please, sir.
Can you see it?
Next slide, sir.
Can you
Now,
see it?
one of the major,
You
one
know,
of the major.
hold on. I guess it's going off every slide time I change the slide. Okay, lactate storm, correct?
One of the major important implication is the role of lactate in traumatic brain injury. If you see that there is a lactate peak within minutes following the severe traumatic brain injury, and one study has shown, especially from the study from Canada, from Calgary University, has shown that there is a glial neuronal uncoupling. That means the lactate cannot go from the neuron to the glial cells, and there is excessive amount of lactate within the extracellular compartment, and this lactate is injurious to the surrounding cells. So extracellular lactate is independent of the brain hypoxic ischemic state in the TBI. Next slide, sir. Now, number of studies have verified the role of raised lactate within the CSF, especially now since there is 3 Tesla MRI, they have done an MR spectroscopy study, and they have shown that within the foci of traumatic brain injury there is increase in lactate peak, especially in patients with TBI. Now, this has a great implication in TBI. Next slide, please. Now, if you look at what are the different genesis by which the lactate is produced within the brain, one of the major issues is the glutamate toxicity, because glutamate will give rise to increase in astrocytic glycolysis with the activation of sodium potassium ATPase pathway. And the role is the role of hypoxia, because hypoxia is an anaerobic environment, thereby leading to the excessive production of lactate. Now, there are two different enzymes that has been implicated in production of lactate within the cells in traumatic brain injury. One is the cytosolic malic enzymes. Now, this malic enzymes, what it does is it causes excessive amount of metabolites from the Krebs cycle and recirculates them into the pyruvate cycle. Another enzyme, that is cyclase enzyme, it activates after there is activation of bicarbonate sensor due to the potassium efflux from the cells. Now, this sensor, once it is activated, it gives rise to increase in glycolysis. Now, these four mechanisms essentially works together within the traumatic brain injury, giving rise to excessive amount of lactate production within the cells. But the main issue is neuronal glial uncoupling following the traumatic brain injury. Next slide, please, sir. Now, there has been recent studies showing whether there is the role of lactate infusion in patients with traumatic brain injury, because lactate in certain circumstances, like it can act as a substitute for a glucose. But it should be governed in mind that lactate can only act as a fluid supplementation only in the aerobic environment. But traumatic brain injury is an anaerobic environment. So if you give excessive amount of lactate, it will be further harmful to the brain, because lactic acidosis gives rise to acidic environment. So lactate in a traumatic brain injury is a foe rather than a friend, because it is a anaerobic environment. Next slide, please, sir. Now, there has been the role of G lymphatic pathway and tau pathways. Now, G lymphatic pathways are nothing but they are paravascular spaces, or simply known as they are the lymphatics, or a crossroad within the brain that helps to drain excessive amount of lactate and tau proteins within the brain. In TBI, there is chronic impairment of this pathway, and this renders this traumatic brain injury vulnerable to tau aggregations. Now, tau proteins are nothing but they are breakdown products of microtubules. What is that? Is that when there is excessive amount of deposition of tau proteins, it causes fibrosis and sclerosis of the paravascular pathway and rendering them to obstruction. Now, when there is obstruction to this lymphatic pathway, there is excessive amount of metabolites within the brain that predisposes it to pre-senile dementia, Alzheimer's, different, etc. Next slide, please, sir. Now, there has been a study that there is, when there is chronic traumatic encephalopathy, traumatic brain injury can prime microglia. Now, if there is single episode of trauma, this microglia, what it does that it switches from resting stage to the neurotropic stage. Now, neurotropic stage, what it does is that it activates intrusion of neutrophils, and it initiates the inflammatory reaction. But what happens is that after a short set of time, this neurotropic stage is substituted back to ramified or reparative mode. That means after a certain period of time, the neurotropic form of neutrophils will change itself into reparative mode. But what happens after traumatic continuous repetitive injury or punch drunk state is that the transition from reparative mode into the resting phase will not occur. So there is a stage of hyperactivation of the microglia, and this hyperactivation will lead to damage to the neurons within the brain. Next slide, please, sir. So in this slide, what we like to emphasize is that TBI has a role to activate the microglial cells, especially the microglial cells, and the neurotropic action is especially in the circumventricular organs within the periventricular zone. Now, what happens is that microglial cells is switch on the neurotropic form and thereby leading to inflammatory initiation. But after some time, it switches back to the reparative or the resting phase. But with the onset of repeated trauma or repeated head injury to the patients, this microglia transition doesn't take place, and there is progressive neuronal degeneration leading to presenile dementia. Next slide, please, sir. Now, one of the topic that we often forget in traumatic brain injury is what is the implication of sleep after head injury. Now, one of the main issue of sleep is that the sleep promotes exchange between of CSF fluid to the interstitial fluid. That means it helps to restore the milieu within the brain. Prudently for timing restoration of the internal milieu inside the brain for its efficient functioning. Studies have proven that lateral and supine position are more favorable for the clearance pathway or the clearance of these metabolites during sleep. Next slide, please, sir. So if you look at sleep, there are different stages within the sleep. One of the most important sleep is the N3 phase of the slow wave cycle. The implication of N3 phase is that the CMRO2 or the cerebral metabolic rate of oxygen is minimum during this phase. Thereby, the brain is in the resting phase. Also, other implications of sleep is that there is pulsatile release of growth hormone as well as pulsatile release of serum cortisol during the phase of sleep. And also, these hormones helps in accelerating the tissue healing as well as they hasten the recovery of the patient with traumatic brain injury. Next slide, please, sir. So sleep is a dynamic process. It is governed by different systems within the brain. Most important are the two systems in the preoptic nucleus and the suprachiasmatic nucleus. Now the preoptic nucleus also gives rise to clock that sets up the sleep pattern within the brain. Another important thing is the suprachiasmatic nucleus, because suprachiasmatic nucleus has a connection with the dorsolateral nucleus of thalamus. Now these two processes, what it does is that it helps in the correct transition of sleep from the within the brain. And another system is the Pons control system. Now the Pons, what is that? It helps in smooth transition from NREM sleep to REM sleep. So what happens to traumatic brain injury patients during sleep can be seen in the next slide. Next slide. So if you look at any patients or traumatic brain injury patient in ICU, there are different issues to the patient that can fragment the sleep in the patient. Most important is the repeated noise, persistent lightning, the frequent physical interplay between the nurses, doctors to the patient, and also traumatic brain injury can damage the hypothalamic sleep regulators in the brain. And most important thing is when there is excited toxicity, there is dysregulation of the neurotransmitters, especially the dopamine. So all these things will fragment the sleep cycle. Now, what happens when this sleep cycle is fragmented is that there will be increased amyloid. In sleep, there is the clearance of the amyloid. So when the sleep is fragmented, this amyloid clearance doesn't take place. And the thing is, there may be excited cognition within the patient. He may have the clouding of the decision-making capacity, and also there is increased daytime somnolence. Now, all this issue will do is that it will fragment the sleep, and there is increased chances that the patient may land up to further injury or further trauma. Next slide, please, sir. So, in a nutshell, our main take-home message through this presentation is that there are near evidence uh, that can be a silver lining in our quest to manage traumatic brain injury. We should have a multimodal approach to the management of traumatic brain injury, and if we consider this pathogenesis, then we can transition ourselves from nihilism to optimism. What we need to focus is that management of traumatic brain injury has two important aspects. One is the internal milieu within the cell. The role of lactate, protein. And another important issue is the crossroad means the working of G lymphatic pathways. Because G lymphatic pathways is the main clearance mechanism within the brain. So if you take into consideration these issues, you may have a great achievement in our patients with traumatic brain injury. Next slide, please, sir. So management of traumatic brain injury regarding flogging a dead horse. Most often with traumatic brain injury management is mainly surgical. That is evacuation of the hematomas that can damage the patient by ongoing herniation. But this thinking should now there should be transition of this thinking to the internal milieu and also the clearance pathway of the brain, especially the G-lymphatic pathway. Next slide, please. So our main take-home message of this presentation is that we should have a smooth transition from the operative point of view to the internal milieu and the crossroad clearance of the crossroad clearance pathway within the brain. Thank you, sir.
Okay, thank you very much for. I was concentrating on the slides. I'll let Ipe lead the discussion and comment part of it. Okay, Ipe, do you have any comments or questions?
Yeah, Sunil, very good talk. A few things. Number one, Sunil was talking about the lactate and the TOG clearance. Now, one of the things that has attracted a lot of interest in the past few years is the lactate stone that builds up in the brain after any traumatic brain injury. So it is in cystonostomy, we always say that the Virchow-Robin spaces are closed off because of lead, and this is chronic. This is not in the acute phase, and maybe 1 day to 2 days later, the Virchow-Robin spaces, the perivascular system is not working, and the lactate clearance is at fault. And when the lactate clearance is at fault, it starts the neurons. They start and neurons and the axons. They start swelling, and what has been conventionally mentioned as diffuse axonal injury may be actually due to the lactate stone that the lactate is building up. So they've done some interesting experiments, and Dr. Garnet Sutherland has written a very interesting paper on this. So this lactate clearance is extremely important, and as Sunil said, sleep is one of the reasons, one of the things that can cause this lactate clearance. So I would say that one of the side effects, positive side effects of cystonostomy is that when you open up all the cisterns, you are creating a backflow, you are opening up the Virchow-Robin spaces, and this lactate clearance may be one of the reasons why cystonostomy works better than decompressor. Dr. Sinha.
Yes. I'm sorry, because of power problem I couldn't connect that time.
Okay, we can't see it. Do you have any questions?
Cherin, can I ask a question?
Beg your pardon?
Yeah.
Can I ask?
Please.
Yeah.
Please. You are one of the moderators.
Yeah. This lactate can be estimated from the lumbar puncture?
Yes, absolutely, yes. But better than a lumbar puncture, what we would suggest is putting in a small drain. When we do cystonostomy, we always put in a drain into the prepondine system. And from there, it is better that you do it from there. But I'm sure you can do a lumbar puncture to assess the lactate.
Okay. Thank you.
Okay.